Welcome to our renal nursing care lesson. You can find this on pages 208 and 209 of your Nurse Workbook 2.0, or you can print the pages below this video so you can follow along with me. The purpose of this video is to provide you with real-world nursing education beyond the Nurse Workbook. So in this video, we're gonna talk about the equipment we use for dialysis. And we just got done learning about the types of dialysis and renal replacement therapies. And in my opinion, it's a lot easier to understand the equipment now that we understand the need for it. So let's learn about these 3 catheters that we use. Our first catheter is our dialysis catheter, and there are many different brand names that you might see in your clinical practice. And this should only be accessed by a dialysis nurse, and this is because dialysis nurses have to go through a particular certification to be able to do this. They've spent 2,000 to 3,000 hours practicing in nephrology in order to become a dialysis nurse. So these are only accessed by those amazing nurses. And these lines are considered a central line. They are meant for short-term use. And our patients with chronic kidney disease that are requiring lifelong dialysis will have an AV fistula that we're gonna go over. So this catheter can be a band-aid while they're waiting for their AV fistula to mature. The next one is a trialysis catheter. This is a dialysis line, but it has an extra port in the middle for our blood draws and our medication administration. This is usually a purple port, and this is dependent upon your hospital who can actually access this port. And we typically see these accessed by our ICU and ER nurses only. And lastly, and the most important one to talk about, is our arteriovenous fistula, or AV fistula. And this is a connection of an artery and vein made by a vascular surgeon to create a large bounding vessel with extra blood flow to tolerate the high flow rates of dialysis. Our AV fistulas take about 3 to 4 months to mature, engorge, and thicken before dialysis can be performed on this site. And these fistulas can last for many years. So if we look down here at our anatomy, we're gonna learn all about what the AV fistula looks like inside. These AV fistulas can be placed in the wrist, in between the forearm and the inner elbow, and sometimes in the upper arm. A lot of times what happens is when one fistula goes bad, they'll do another one either in the other side, or they'll try to keep it in the same arm, but they're gonna move locations. But again, it can take time for these to engorge. So always be cautious if a patient has a fistula in an arm, and remember, we cannot take blood pressures in these arms. Jumping into a forearm AV fistula, our vein access is going to run along right here. And then we have our arteries that also run along. So we're going to connect this vein to our artery, and it's going to expand due to the increased blood pressure of mixed arteriovenous blood. And then our catheters, one is going to be inserted that goes to the dialysis machine, and the other one is going to be coming from the dialysis machine. So this way the machine can pull the waste off but put back the new cleaned fluid in. But there are 2 cautions we want to take about hemodialysis. So number 1, our hemodialysis lines are locked with heparin or sodium citrate. So we always want to aspirate before we access these lines to avoid bolusing a patient. So this means if there is heparin or the sodium citrate sitting in this line to make sure it doesn't clot up, we don't want to just push saline straight through it because we're going to bolus our patient with that heparin. Instead, when we put the catheter up to this access point, we want to withdraw so that way we don't shoot that heparin into the system. And secondly, our patients should not eat during dialysis, and this includes tube feeding. Our digestion will divert blood flow in an already hypotensive patient. Sometimes I've walked by hospital rooms and seen our patients eating in the middle of dialysis, and some patients can handle this. Our patients that have been on dialysis for a long period of time usually can handle eating and having dialysis performed, but typically that dialysis nurse is going to know this patient very well. for the most part, we should not be feeding patients when they're getting dialysis, because dialysis can cause hypotension since we're pulling that fluid off. And since that blood flow is going to revert to digesting its food, this can make that patient even more hypotensive, which we totally want to avoid. And this concludes our renal nursing care lesson. I'll see you in the last renal lesson next.